Good evening and welcome. Hi, my name is R. Nazarian. I'm a practicing dentist here in Michigan, and tonight's webinar is Simplifying Overdentures in Today's Economy. These are the types of patients that are presenting to your office, and these are the dental issues they are presenting with, whether it's multiple teeth or a full edentulous arch. This is what we're seeing in today's economy. However, not everyone can afford a full mouth reconstruction with fixed bridges. So, as practitioners, what do we offer to our patients? Overdentures is an affordable option in today's economy. Whether it's O-balls or locators, overdentures will provide some type of stability for our patients that cannot afford fixed bridges on implants. So let's take a look at an example. New dentures with small diameter implants. This patient presented to my practice with these existing dentures that were over 17 years old. He was not only dissatisfied with the look, but also the feel and fit of his dentures. Upon closer examination, not only do we see the staining in these dentures, but we also see that the bite is a class 3. We also notice that the lower ridge is not very retentive at all. During the consultation, we went ahead and took aluminum foil from a film, placed it on the internal aspect of the denture, and took a lateral extraoral film of this patient. Upon examination of this film, we can clearly identify where we need to place the small diameter implants. So we presented to the patient the situation of 4 on the floor, placing 4 small diameter implants anterior to the mental foramina in the lower ridge. Once the patient agreed to this type of treatment, we quickly took the molds for a new set of dentures. In order for the implants to be successful, we needed a stable denture with an ideal occlusion. Utilizing adhesive for impression material, we coated the internal aspect of both his upper and lower dentures. Using a medium body impression material, and in this case we used Take 1 Advance from Kerr, we did a reline impression of his lower and upper arches. We also took a bite in order to give relations to our local lab. We sent these impressions to the local lab, and they went ahead and poured them up, and a week later they had a wax trying of the teeth for the patient to visualize and see if he was happy with not only the size, shape, and color. The patient obviously approved it. He was very pleased with the look, but also of the bite of those teeth. So we went ahead and had the lab process within a couple days, and this is what the retracted view of his new upper and lower denture looked like. Notice, in comparison to his old denture, not only did we correct the bite, but we increased the vertical dimension. Patient's new smile is bright and functional. However, he still wanted to have some stability in the lower denture. Because of this, we recommended the small diameter implants, and he was now ready to have the small diameter implants placed. Before we anesthetize the patient for the small diameter implants, we utilize gutta-percha points and sticky wax. We placed them from canine to canine, and we took a new Panorex x-ray with the dentures in the patient's mouth. What we did is we take a look at the Panorex x-ray, and we clearly see that now we know where to place the small diameter implants. Here we have the setup for the small diameter implants. Our goal was to use the 2.2 by 12 millimeter Oco Biomedical iMicro implants. We anesthetized the patient, and utilizing a tissue punch, we only removed the tissue in the areas of where the implants were to be placed. If we take a look at the pilot drill, we can clearly see where the markings are for the lengths. We went ahead and used a surgical stop at the 12 millimeter mark so that we would not drill any further. Using the AEU 7000 from Aseptico, we went ahead and went to depth with the pilot drill. We utilized the 20-to-1 reduction handpiece at about 1800 RPM with a flow of surgical saline of about 90%. One thing that I like to do is I will refrigerate the 250 mils of saline before use. And so not only are we using irrigation, but we're using a cooler irrigation. Now we have our eye micros ready for insertion. Utilizing the driver in the OCO Biomedical kit, we started from the most mesial implants and moved our way to the distal. Here we have rubber dam blocking out any undercuts when we're ready to do the pickup of the female components or metal housings. We've already relieved the internal aspect of his lower denture, and utilizing quick-up material from Voco America, we filled the access openings about 3/4 of the way up. We seated it in the patient's mouth, and any excess was trimmed off, and any voids were filled with quick-up light cure material, which essentially comes in a flowable composite syringe. So we're able to identify the areas of the voids, fill in this material, and light cure it, as seen in this photo. Here, if we take a look at the positioning of the implants, we notice they are not only parallel, but they are within the gutter puncture points as we talked about. Retrofitting an existing denture with small diameter implants. Here we had a patient present complaining of a non-retentive denture, and when he did use glue, he found that it was causing him to gag because of the posterior palatal seal. We take a look at the maxillary ridge and we notice that it is not very retentive. However, there was enough bone buccolingually to place small diameter implants. These are the eye minis from OCO Biomedical. The size selected was 3x12 for all of these implants. And this is the day of surgery. You can see how atraumatic this procedure is. We take a look at the radiograph and we can clearly identify that the implants are placed properly and all the threads are within bone. We went ahead and relieved the internal aspect of his denture. Using a rubber dam, we blocked out any undercuts and snapped on the metal housings. What I will do then is trim the excess of the rubber dam so that there's not any excess in the pickup impression or hard pickup. So we'll go ahead and trim any of the excess. I found it's easier to use one piece than the separate squares now, as long as we trim the excess. We filled the relieved areas in his internal aspect of his denture with the quick-up material that extrudes from a self-mixing tip. This material is very easy to use, and because of the viscosity, I find it to have very little voids ever. So we see that we filled this 3/4 of the way. We have that placed into the patient's mouth and we have them bite together. We allow the material to cure. Once the material has cured, we'll go ahead and relieve any areas that may be some excess flash. And now that he has a more retentive upper denture, our goal is to relieve this posterior palatal seal that was causing him to gag, as seen here. Now, in the patient's mouth, we can clearly identify that the palate is somewhat free of this denture. If the patient chose to upgrade to a palate-free metal reinforced overdenture, we could remove the majority of that palate and do what we needed to do as far as relieving the palate. However, the one thing is, if we relieve the whole internal aspect of this palate without metal reinforcement, this denture could easily break. So what I will do is relieve some of the palate, maybe 3/4 of the way. If they choose to go with a metal reinforced denture, then at that point I will go ahead and relieve the whole denture. Now, there's a question here that asks about having access openings or relieving the internal aspects some more, having vents for the material to flow. I found that I really don't have to do that because I'm not filling the access all the way. If any is relieved, it'll be relieved as flash, and I can quickly remove it. What I found is if you make vents, many times not only does it extrude out of the vents, but one cannot get the polish on that internal aspect like a laboratory can, and so then the patient's tongue starts playing with the lingual aspect of those vents. So I will purposely not place vents myself. Here, if we take a look, we see the patient is smiling big, he's no longer gagging, and most importantly, his denture is not coming out. Immediate extractions, grafting, leveling, and immediate dentures with implants. Here we have a patient who presented to our practice. This patient presented with constant throbbing pain, tenderness to hot and cold, and mobility with the majority of these teeth. Upon radiographic examination, we saw long spanning bridges in the posterior mandible, in addition to advanced periodontal disease in the lower anterior region. In the upper arch, we also noticed that there was quite a bit of decay as well. Notice on the lower region how inflamed the gingival tissue is from canine to canine. One concern we had was when we were taking impressions for the immediate denture that some of these teeth may come out in the impression. Fortunately, this did not happen. We anesthetized the patient. A week prior, we had already taken the molds for the immediate dentures, so they were already fabricated the day of surgery. And utilizing the physics forceps from Golden Dental Solutions, we atraumatically extracted the patient's upper dentition. Usually I will start with the upper teeth, level the bone, graft the areas and suture, and place the immediate denture, and then move on to the bottom arch. So this is what the standard set of physics forceps look like from Golden Dental Solutions. Here we see the teeth were all atraumatically extracted without breaking any root tips. When we take a look, we see that very little trauma was induced in the gingival tissue of this region. However, in immediate dentures, I like to reflect a full flap once the teeth are extracted, and then I like to level the bone using a bone leveling burr. This is from Axis, and again we use the surgical motor and handpiece from Aseptico. I make sure that I use copious amounts of sterile irrigation, and by removing these sharp tines of interdental bone, we find that patients complain of their immediate dentures much less than if we don't remove these sharp tines of bone. So routinely I will reflect a flap, reduce these sharp areas of bone, check it with my finger and confirm that they are smooth, and then I will go ahead and graft the areas. And so whatever bone of choice you like to choose is up to you. In this case, we're using the bone grafting material from Oko Biomedical. This is a particulate graft. If you like to use the putties or gels, that will work as well. We went ahead and sutured this close, and then we went on the lower arch and we extracted these teeth sequentially, as you can see. utilizing the physics forceps from Golden Dental Solutions. And in the lower arch, because the bone was much more stable and solid, more like oak wood, we placed 5 3.7 by 12 Engage implants from Oko Biomedical, and we did these freehand. Notice I reflected a full flap, leveled the bone, placed the implants, and then I grafted the areas where there were still some voids, resutured this patient, and utilized the Ufi Gel Soft Reline from Voco America. We allow this area to heal. Now, one pearl that I like for you to take home this evening is when utilizing this material or any soft relines, our concern is always to not pull the stitches out from the site. So not only will I trim the stitches to a short length, but in addition, I will lubricate the sutures with some KY jelly. And I like to use the KY jelly because it's water soluble as compared to Vaseline. If you use Vaseline and the Vaseline is not completely removed, then what can happen is the tissue areas that were cut may not heal together. So I prefer to use the KY jelly, which is water soluble. 3 months later, we see the upper arch has healed very nicely. We look at the lower arch 3 months after surgery. We see that the patient has quite a bit of tartar buildup on the healing caps that are already exposed, that have exposed themselves. And we know that we need to expose the 2 other healing caps in the patient's lower right arch. So utilizing the Picasso laser from AMD Lasers, we set the setting at about 3. And utilizing this laser, we atraumatically removed the gingival tissue that was covering these 2 implants. We started first from the most distal implant. We exposed that entirely, and then we moved on to the implant that was slightly more mesial. And again, using the AMD laser, the Picasso, we went ahead and exposed this implant as well. The beauty of this laser is it's very cost effective. It has quite a bit of power at 7 watts, and it works very well when you move it from one operatory to another. Once these 2 housings, or excuse me, healing caps were exposed fully, we went ahead and removed all the healing caps and placed new taller healing caps so that when this gingival tissue heals, it would heal completely around these taller healing caps. 2 weeks later, we went ahead and removed the healing caps and placed Zest locators for an overdenture system. We placed the blockout shims as well as the female components, which are the locator housings. We confirmed that there was a passive fit. Now, there was a question earlier of how do we identify where to relieve the denture. Well, one is the Thompson sticks, where you wet the stick and it leaves like an indelible blue ink on the housing, and we try to seat the denture and we see where it marks the denture and we relieve it. Another thing that I've used that comes in the Quick Up kit is the Crown and Bridge fit test. This is like a silicone material, and once it's placed on these housings and you seat the denture, it will stay within the denture, and so then you'll go ahead and relieve the internal aspect of the denture in the areas of where the check, the fit test check has identified them, and we'll see pictures of that later on. We've identified the areas where we relieve the denture. Utilizing the Quick Up material, we've placed Quick Up material into these areas, and this is from Voco America. In addition to placing the material inside of the denture, I routinely will place it over the housings as well. And what I found is that not only do you no longer have problems of the material not sticking to the housings, but most importantly, you have very little voids present. So this again is the quick up material from Voco. Here we see that we've not only picked up the housings, but in the little areas on the facial aspect where there's a little bit of a lip or void, we're using the quick up material LC. LC meaning light cure. And so by light curing these areas, we don't have to worry about using a material to pick this stuff up or to relieve it again and do it again and again. By using the quick up LC, we just clearly fill in the void and cure it with a light, and we are finished, as you can see. Now, we're going to allow this patient to go with just these processing inserts in the locator housings for another month or so, and then at that point we can use either the clear, the blue, or the tan and go up to 5 or 1.5 pounds of retention if we would like. Here we see the housings, or excuse me, the locators 1.5 years later. Notice the gingival tissue is very healthy around the locators. The patient is not doing the greatest job of keeping the food from getting in there, so we went over instructions with this patient to go ahead and clean out the internal aspect of these housings. Let's take a look at another case. Immediate extractions, grafting, leveling, and immediate dentures with implant placement. As indicated in the introduction of this webinar, we are finding more and more patients that are presenting to our practice that are presenting with huge amounts of decay or periodontal disease. What I found here in Michigan, that patients have put off dental treatment for so long that when they finally do present to the office, they need a huge amount of services to get them to proper health and function. So this patient presented to our practice, and it doesn't appear that his smile is that bad when he's smiling. Upon the retracted view of these teeth, we see not only does he have huge amounts of gingival decay, but also periodontal disease. So we went over a variety of different treatment options, and in this patient's case, he decided to go with an upper overdenture and a lower fixed bridge. Here we see the vast amount of decay in the upper arch. Notice that his previous dentist splinted the anterior teeth together because they were mobile for so many years. And the molar, in fact, could come out with a 2x2. In the lower arch, there were several areas of decay that were far below the gingival tissue, in addition to periodontal disease. So our treatment plan of choice was to go ahead and extract these teeth as well. Impressions were made for an immediate denture a week before the IV sedation case for this patient. When doing multiple extractions, leveling, grafting, and implant placement at one time, I will always recommend IV sedation. Utilizing the physics forceps, we went ahead and initiated the extraction sequence for this patient. As you can see, we're sequentially moving our way to the back. Here we've extracted the splinted teeth. We've leveled the bone, and we start placing grafting material. One thing that we didn't capture on film that I will routinely do is once these teeth are extracted, we will use a curette and clean out any areas of tissue, of cystic material, and then we'll go ahead and take our AMD laser, the Picasso, and put it on a setting of about 1.5, very similar to a setting of what you do when you're doing periodontal therapy. and we sterilize that area as much as possible with the laser. Without causing burning or cauterization, we're essentially disinfecting that area. We'll irrigate with surgical saline to remove any excess debris, and if necessary, we'll go ahead and use a round burr to remove any other things as well. Now, we've gone ahead and grafted, we've gotten primary closure, we've used membranes also, the conform membranes from Ace Surgical, and we go ahead and now try in the immediate denture. When doing immediate dentures in these cases, because of leveling and because of the irregularity internally of this denture, we'll go ahead and use the Eufy gel from Voco America and do a soft reline for 3 to 4 months before placing any implants in the upper arch. In the lower arch, we go ahead and sequentially remove the teeth, and one thing you'll notice here, when we remove the teeth, quite a bit of bone came off with the teeth. This patient had very thin bone, and for some reason, I don't know if it was because of the periodontal disease, but when we removed these teeth, quite a bit of bone came out with the teeth. So our goal is to level this bone so that we get adequate width and adequate stability of a type 1 or type 2 type bone. So as you can see, we've sutured the floor of the mouth out of the way, and we start to level the bone. This is something that I've learned at the Misch Institute from Dr. Carl Misch. We maintain the premolars so that we can position our A to E position, since we were not using a surgical guide in this particular case. We placed our first initial pilot hole with corresponding paralleling pin, and utilizing the Engage implant. This is a 3/7 by 12. This is the Engage from Oko Biomedical. I like these implants that are aggressively threaded, and so we start to place that first, as you can see. And here we have the 5 implants from the A to E position. Notice the interdental, not only the buccal bone, but the interdental bone that came out with these teeth. This is not because of the method of extraction. This is just because of the type of bone that was there and the disease bone that was evident. Here we see the 5 Engage implants from the A to E position. Here we see the soft reline that we utilize, and this is the Eufy gel from Voco. Notice the patient is out, so we're having him bite together by pressing his chin and his maxilla together. Now, in these cases of immediate dentures, if for some reason the midline is off, we're not too concerned because we're going to be making him a new set of dentures. When looking at the discrepancies in jaws, we're focused more on the upper arch of where the midline is, not the lower arch. Either due to discrepancies in arch form or crossbite, sometimes the lower arch will not correspond, the midline in the lower arch will not correspond with the midline in the upper arch. Most people will not notice that. We as dentists will, but for patients, they're happy that they have white, bright teeth that function and that they can smile with. So as long as your midline in the upper arch is ideal, that is very good. 8 weeks later, we take a look and we have the custom abutments from Burbank Dental Lab. Now, our anterior-posterior spread from these implants is not the most ideal because the patient did not have posterior teeth, and we did not want to go distal to the mental foramina because of the undercuts and because of the nerve. So our goal is to do a cantilever type bridge, very similar to the type that are talked about in Misch's book, Contemporary Implant Dentistry, 3rd volume. And so here we have a DuraTemp. This is what we call an FP3 restoration. FP3 meaning because of deficiency or in bone or because of the reasoning of leveling the bone, we do not want to have very long teeth there. So not only will the restoration have teeth, but it will also have pink acrylic or pink porcelain. Now we have the porcelain fused to metal FP3 bridge. Notice we only went back to the first molar and we skipped a premolar. We told the patient that this would be a limitation unless he wanted to go with block grafts in the posterior region of the mandible. And here we see the FP3 bridge from Burbank Dental Lab. We cement this into place and clean the excess cement. Here we see the retracted view, and the patient is happy that he's got a fixed bridge. We look at the occlusal aspect, and the patient is pleased because these are porcelain teeth, not plastic teeth that may discolor or screw holes that may get some accumulation of problems. If need be, using the Dent Corp pneumatic crown remover, we can tap these off if necessary. Looking at the upper ridge, we see the healing 4 to 5 months after extraction. We were a little hesitant to place implants freehand in this ridge because of some of the voids in the areas of bone. So we went ahead and had him scanned. Utilizing the treatment planning services from 3DDX, which is 3ddx.com or 3DDX or 3D Diagnostics, we treatment planned 3.25 by 12 implants, and these are from Oko Biomedical. These are 6 implants, and we would prefer to have them in ideal locations, but we went by the scan and where there was the most bone. As you can see, some of the areas that were grafted did not take. The patient was going to have 4 implants. That's what he paid for, and we went with 6. Routinely, I'll always put more than what they've paid for. That way, if one does go bad, the patient's not too alarmed as compared to them paying for 6 and one goes bad, then they get alarmed or want some money back. So usually what I'll do is try and place more implants. Here, if we take a look at the transparent view, we see where our ideal areas of bone are for these 6 implants. So we went ahead and utilizing the services from 3D Diagnostics, we went ahead and had a surgical guide fabricated. These are the areas. Routinely, I will use a pilot guide. There are 3 different types of surgical guides one can use. One is a pilot guide where only the pilot drill goes through and creates the first pilot osteotomy. A second type of guide is a universal guide where it's a larger diameter opening, and using different size keys, you can sequentially go bigger to larger size drills and implants. Or you can use multiple guides that are used for sequentially larger drills, and then later you can also put the implants through it. The most cost-effective surgical guide that I use routinely is a pilot guide. And since in the Oko Biomedical kit, the sequential drills are only side cutting, not end cutting, all I do is passively follow the osteotomy, and I have yet to have a problem utilizing this technique. Most importantly, it's much more cost-effective than using multiple guides. So 4 to 5 months later, we see that the gingival tissue has healed very nicely. Utilizing our pins, our retention pins, we stabilize the surgical guide. And here we see the single-stage TSI Oko Biomedical implants placed in the areas that we treatment planned. We place the locator abutments onto these areas. We allowed the area to heal for about 3 to 4 months. In this particular case, we went a little faster because of the aggressive threads. Most of those implants went in at a torque resistance of about 65 to 70 Newton centimeters because of the patented auger tip, as well as the aggressive cortical threads. Now, the fit check that we spoke about earlier this evening can be seen utilized in this particular case. If you notice, there is a good size undercut in this area. The last thing we want to happen is for hard pickup material to lock onto this implant or in this area. So to prevent this, we utilize the Fit Check Crown and Bridge from Voco. We syringe this in any undercuts, cure it with a light, and this material is like a rubbery or silicone type material. So it will come out with the reline without causing any lock-on of the denture. You see, we've also used the block-out rings for any small undercuts underneath the housings. So we've identified the areas and transferred that using the fit check. We relieve the denture, and here you can see we've loaded it with the quick up material. Notice again, I do not use vents when doing this. We relieved any excess, removed the processing internal housings, and placed several retentive plastic caps. Notice in the canine areas, because the implants are angled slightly more, we went ahead and used the housings that allow a little bit more angulation in the pickup. So here we see a pallet-free overdenture that's metal reinforced. And looking at his Panorex, we can see we've avoided any anatomical areas that may pose a problem. We notice that the FP3 bridge in the lower arch is very stable and going strong. And now on the upper arch, we have a overdenture that's sitting on implants with the overdenture, the Zest locator overdenture system. Now, most of our denture patients will say, I would like white teeth or bleach shade teeth. Fortunately, in the IPN portrait, in addition, the blue line teeth, we find that now they all offer bleach shades. So looking at the patients before and after, we see how much more happier this patient is with his new functional smile. Upgrading dentistry with lower fixed bridge and upper overdenture. Here we have a patient with upper and lower dentures. Here we see the Panorex view. In order to do a fixed bridge in the upper arch, we would definitely need to do sinus lifts. Again, my goal in my practice is not only to be able to provide all the services under one roof, but also try to do it effectively and stay within their budget. So when presented to this patient of doing sinus lifts in the upper arch for fixed bridges, the patient said he was okay with an overdenture on 4 implants and a lower fixed bridge. His concern was more the fixed bridge on the lower. So, utilizing the planning services from 3D Diagnostics, this is what the virtual treatment planning looked like by placing 8 traditional size implants from the Oko Biomedical line. Here we have a universal surgical guide just to show you that we have used the variety of different guides that are out there. In this guide, we use a variety of different size sleeves or keys and sequentially go to larger size drills. Once the implants were placed, we took x-ray and we saw that all the implants look nice. We went ahead and placed the solid abutments the day of surgery, again because we had quite a bit of resistance, and we're going to be placing a temp that's going to create dual arch stability for these implants. Here we see the radiograph, Here we have the temporary hybrid denture that's relieved, and we cement this on with Temp-On Clear and allow this patient to use this in function for a few months. 3 months later, we prep the abutments if necessary in the mouth, and we take a regular crown and bridge impression. Here again, we have the FP3 bridge created by Burbank Dental Lab. In this case, we utilize the Maxim Elite Cement. Again, we'll put this in 2 pieces because of the flexure and torsion of the mandible. We don't want to have it as one piece, so we separate it between the canine and the lateral. And here we can see the full Panorex view of the lower arch. The patient was so pleased with this, he was indeed now ready to go ahead and have the upper arch retained with implants. So the first thing he told me is, "Doc, I want to have this palate removed. Can we accomplish that by doing an overdenture? I don't want to go through a sinus lift technique on both sides." I said, "Not a problem." So our goal is to remove the palate and to place 4 of the Oko Biomedical implants in the premaxillary zone where there's sufficient bone. Here we have the wax rim for try-in. And so if our planning was to place 4 of these implants, what type of attachments would we use? Because there's a variety of different attachment systems out there. My preference is the locators from Zest. Not only does it have a lower profile, but I found that we can change the different types of retention on it if the patient wants something tighter or looser. Most importantly, this system is self-aligning. It helps patients correctly seat their overdenture into place, and also it helps eliminate the wear and destruction of the attachment components from improper seating. So it's self-aligning, which is nice. Most importantly, it does have a proprietary pivoting feature. There are several different systems out there. I have found that the Zest locator is the true locator and the true overdenture attachment that really allows for high mastication forces and to compensate for implant divergence, as you saw in the previous case. If we take a look, we see the implants are placed as well as the locator attachments. Utilizing the blockout shims as well as the housings, we're going to identify with an indelible pen, or we can use the fit test check. We've relieved the areas, and we've already identified the areas because of our virtual treatment planning. So the laboratory, in fact, had already relieved the areas in the framework that were ready for us. And so this one, I believe, was fabricated from Glidewell Dental Lab. We went ahead and used the quick up material in those recesses. Again, I will routinely not put vents when doing this procedure. I will routinely just fill the areas 3/4 of the way. If it looks like it's all the way to the top, then what I'll do is take a Q-tip and remove some excess before seating them onto the housings. I'll press first lightly, and then I will have the patient bite in CO once I've confirmed the position of the denture is accurate. This is what it looks like. Notice any flash we're going to relieve now with a fine laboratory burr from Access. The nice thing again with the quick up material is very little do I ever get voids. However, if I do, I can quickly clean them up and repair them utilizing the quick up LC material. So in 2011, this is the palate-free overdenture that we delivered, and in the lower arch we have the FP3 bridge. Now, the patient is instructed to use a water pick to keep this area clean and to maintain this lower bridge. He is also instructed to come into the office every 4 months for a cleaning. So as dental providers, Our goal is to instruct our patients on how to maintain and clean these. However, we cannot hold their hand and be at their homes every day and every night to make sure that they're going to do this. So if they're not going to take care of their investment, I'll be more than happy to take care of them and do a new procedure for them at that point. What I have found in my 15-year experience of doing this is when people put this type of money into their mouth, they do take care of their investment. Here we can see the 4 TSI implants in the upper arch that are ideally placed thanks to the treatment planning services from 3DDX, as well as in the lower arch. Let's take a look at another case. Immediate extractions, grafting, leveling with immediate dentures, and delayed guided implant placement. Here we have a patient that's dissatisfied with his smile and broken teeth. He actually complained quite a bit of discomfort. Being a truck driver, my concern was that he was taking quite a bit of pain medications with narcotics because of the constant pain he was in. So our goal was to relieve him of any pain and to do so without multiple visits. After reviewing the treatment plan with this patient, we decided it was best to have all his upper teeth extracted. His lower dentition was still within reasonable limits and just needed a couple fillings in a few teeth. However, the upper arch underneath not only these crowns but also in this longer span bridge had severe decay. So the treatment plan of choice was to fully extract his upper teeth, level the bone, graft this area, deliver an immediate denture and allow the area to heal. 4 to 5 months later, take a CT scan and to go ahead and place implants. Here we have the physics forceps where we took out all the teeth. We smoothed down the bony areas. We placed graft material of choice. Here there was a question earlier about the type of membrane that I like to use. This is the conform membrane from ACE. Dynamatrix is another one that's very good from Keystone. Zimmer has another good one. There's a variety of great membranes that are out there. We went ahead and sutured this patient and delivered the immediate denture. Again, relining this with the UFI gel from Voco America. 4 months after extractions, we see that the ridge has healed very nicely. So we have this patient scanned. We had a clear duplicate fabricated of his denture utilizing gutta percha points. We scanned this, and when doing this, we'll do the dual scan technique. The dual scan technique means the scanning will consist of the denture on a countertop and then the denture in the patient's mouth. So looking at the virtual treatment planning from 3DDX, we can see we're going to be placing 6 implants for the overdenture. Here, 3DDX had the surgical guide fabricated. Again, this is a pilot guide. Using the retention pins, we place the osteotomy or the holes for the retention pins, stabilized the surgical guide, and then went ahead and used our pilot drill. After that, we went ahead and used our tissue punch. In this particular case, we used the internal hex implants from Blue Sky Bio. We placed all these implants in the anterior region. They were 3/7 by 13. In the 2 posterior areas, they were 4/1 by 13. We placed taller healing caps and allowed this area to heal. Then we went ahead and put an overdenture attachment system in those implants, using again the retentive caps Here you can see we're using the Quick Up adhesive within his palate-free denture. We'll light cure that. Then we'll put the Quick Up material not only on the inside of the denture, but also we'll coat the outer aspect of the female components or the housings. We'll place this on first by hand, and then we'll have the patient bite down. And so we'll go ahead and relieve any excess flash, as you can see. Another thing I'll do is I'll coat Vaseline. I'll coat Vaseline in these areas so that the material doesn't lock on, so when I trim it, it just pops right off. Here we see a palate-free metal reinforced overdenture. So we see the before and after. Immediate extractions, grafting, leveling, and immediate dentures with implants. Here we see a patient that presented with gross decay and gum disease, as seen by the Panorex view. Our treatment plan was to fully extract all her teeth. So we went ahead and extracted all her upper teeth using the physics forceps. Notice I'll work in quadrants and always use a throat pack because these patients are sedated. Here we took the whole bridge out. We try in the upper denture, and then we'll do our upper reline with the UFI Gel Soft. In the lower arch, we extracted all the teeth using the physics forceps. We reflected 2 flaps, leveled the bone, and immediately placed 2 Oco-Biomedical TSI implants. We lasered this little area in the anterior portion. Here's the UFI Gel from Voco. What I'll do is I'll use the impression wine glass from Zest inside the reline material. This way we also can utilize the retention of the locators. And so this is what the UFI Gel Soft Reline looks like. Here we have the patient biting together. And this is the Panorex immediately after. We can see the 2 implants with Zest locator overdentures. Attachments. This is 3 months post-operatively. We see the gum tissue is healing. This is the upper arch. And so now we have the final dentures fabricated. And here we can clearly see how pleased the patient is. If you take a look at her eyes, what I tell people is the eyes don't lie, and we can see how this patient is very satisfied with this denture. In fact, she referred several patients to our practice. I wanted to take this opportunity to thank everyone for listening this evening. For more information on courses that I offer, please log on to aranazariandds.com. In addition, on Saturday, March 23rd in Chicago, I will be presenting with a friend of mine, Dr. Paresh Patel, extractions, grafting, and implant cases. So if you're interested in that course, please log on to aranazariandds.com and we can go into that further with you. So let me answer some questions really quickly.